So Chapter 11, the Cardiovascular System, Part 2. We've already looked at the anatomy and the pathway of blood through the heart. We are now going to go and describe some of the pathologic conditions, as well as continue to expand our vocabulary with our combining forms, look at some laboratory tests and clinical procedures, as well as hopefully you'll be able to apply this knowledge to other contexts. So some tricky words: patent, there on the left. Patent means open. If a vessel is patent, is open and flowing. Some pathologies and diagnostics that I want you to be aware of, besides just your terms, is aneurysm is a widening, bulging out of a vessel, and the concern is that it might rupture. Cyanosis is an abnormal condition of blue due to lack of oxygen to the tissues. Deep vein thrombosis is an abnormal condition of clot in the deep veins, usually in your legs, especially in your calf. ECG or EKG we've talked about before. I want you to be familiar with these abbreviations though. Electrocardiogram or electrocardiography, the process of recording the electricity of the heart. Echo is short for echocardiography or echocardiogram, and so that is the process of recording an ultrasound of the heart. But because the heart is a moving structure, we use echo because they bounce off that moving structure. Hemorrhoids are varicose veins in the anal rectal region, so they're bulging, twisting veins. Ischemia is a blood condition of holding back, so if oxygen and blood flow is not getting through to tissues, it could be ischemia. In the first video, we talked about sphygmomanometer is an instrument to measure the pulse pressure or your blood pressure. And tetralogy of Fallot, I want you to know tetralogy, the study of four. These are four congenital defects of the heart. Fallot is an eponym. You don't need to know the specific defects, but know that it is four pretty serious defects of the heart. So on 410, you're going to start to go through the terminology. I'm going to let you go through a lot of that on your own, but I'm going to point out some specific ones here, such as arterial sclerosis versus atherosclerosis. So sclerosis is hardening, arterial of the artery, and athero is fatty plaque. Clinically, these symptoms seem to run together. Fatty plaque builds up in the lining of the arteries, actually embeds itself in the endothelial wall, not just in the lumen. You can see how then that tends to block off the flow or the availability of flow through those arteries. You can see it dissected here at the bottom, all that fatty plaque, atherosclerosis, and here is dissected. You can see how narrow that lumen is then because of all this fatty plaque that has embedded itself into that endothelial lining. So arterial sclerosis, hardening of the artery, atherosclerosis, hardening of fatty plaque, but they usually occur together. So continue to go through some of those words, and on the next page that there is that atherosclerosis, and then further down is when we have this arterial sclerosis or atherosclerosis occurring in the heart, we call it coronary artery disease, which we'll talk about more later, and that can cause ischemia or blockage of that blood flow to go through there, holding back from that distal area. And then we worry about that area becoming necrosis or necrotic or infarction, death of the tissue, as in a myocardial infarction. So we'll talk about that more later. Further in your blue terms, you have cardiomyopathy. And so this is disease of the heart muscle, and it becomes very enlarged as it's trying to work very hard in there. Bradycardia and tachycardia are some of your terms. This is a condition of a slow bradycardio heart, so a condition of a slow heartbeat, usually less than 60, or tachycardia, a condition of a fast heart, faster than usually 100. And we're not about interpreting EKGs, but A is a normal sinus rhythm, a regular heart rhythm. B is slow, bradycardia, and C is tachycardia, fast. It might be normal at rest to have a slow heart rate and during exercise to have a fast heart rate, but these can happen at other problems as an abnormality as well. So coronary arteries are the arteries pertaining to the heart, and they sit on the outside of the heart here. They come off of the aorta, and you have your right coronary artery, and the left coronary artery divides into the anterior descending and the circumflex, and that's what feeds the heart muscle there. Under rhythmo, be careful with the double R in there. Arrhythmia is technically a condition of no rhythm or electrical current in the heart, and dysrhythmia, they drop an R in there, but that's a condition of bad rhythm of the heart. Clinically, we use these interchangeably, so be careful with that, and then watch that arrhythmia is a double R and dysrhythmia is a single R. So I'm going to go into the pathologies now. If you're having arrhythmias or dysrhythmias, then you might need to be defibrillated. And so here is a picture of an implanted defibrillator or an AED that can be used by community members, or in the hospital we might have a traditional defibrillator too that we can shock your heart out of a bad rhythm and hopefully restore a good rhythm. Your book does talk about some examples of arrhythmias. Bradycardia rhythms could be like you saw on the slide before, or it could be different types of blocks where the message isn't always going through from the top of the heart, the atria, to the ventricle. We're not in rhythm interpretation course, so don't stress too much over these rhythms. We can also have a fluttering, which is rapid but regular, or a fibrillation is a rapid irregular, and these can happen in the atria or in the ventricle. If you have atrial fibrillation, though, it is lethal and you will not be alive with that. You'll need to have CPR and a shock with that. Congenital, question for you here first. So don't stress over this one, but extremely rapid but irregular beats would be fibrillation. Atrial fibrillation you can live with. Ventricular fibrillation is not compatible with life. So talking about some congenital heart defects, coarctation of the aorta is a narrowing of the aorta, which is going to cause it to be very hard for the heart to pump that blood through the narrowing, and we can go in there and repair that and correct that. A patent ductus arteriosus, meaning open. So normally in utero, you have a pathway that connects the aorta and the pulmonary artery because you're not breathing, you're getting oxygen from your mom. Usually upon birth, with taking your first breaths, that little duct in there will close, but in some people it doesn't, and then blood flow can actually go from the higher pressure of the aorta back to the pulmonary artery, which would take another trip through the lungs back to the left side of the heart. Not a big thing as far as symptoms. We'll watch it and monitor it, make sure that they don't become too symptomatic with it. If we listen with a stethoscope, we will hear a little bit of swishing or a murmur noise of that blood flow just going a different path. Patent ductus arteriosus. Now, I said I wanted you to be aware of the tetralogy of Fallot, but before I talk about that, I'm just going to talk about a septal defect. The septum was the wall down the center of the heart, dividing the right and the left, and we could have an atrial septal defect, or here is a ventricular septal defect, which is a hole in that wall. And again, normally not such a big deal. The pressures are greater on the left side of the heart, so blood will flow from left to right. Take another trip around the lungs and back, and we'll hear that little murmuring and monitoring the patients to see if it becomes too symptomatic. But tetralogy of Fallot, the study of 4 congenital defects, with this becomes a serious problem when they have all 4. First is pulmonary artery stenosis, or narrowing of the pulmonary artery, which is going to make it hard for this right heart to pump that blood through that pulmonary artery. So to compensate, the right ventricle is going to hypertrophy or increase development to become stronger and try to be able to pump that blood through that narrowed pulmonary artery. Now, they also have a ventricular septal defect, but because of the hypertrophy and the higher pressures on this right side of the heart, it's actually higher pressures than the left, and deoxygenated blood will now flow from the right to the left. But to make matters worse, the final fourth error is the shifting of the aorta to be more in line over the right ventricle. So now it's very easy for this right ventricle, instead of pumping through this strictured stenotic pulmonary artery, to pump into the aorta. So we'll have lots of deoxygenated blood going out to the body, and sometimes these are referred to as blue babies. We will monitor them, and we will need to do surgical correction on this probably sooner rather than later. So the 4 defects you do not need to know, but they're pulmonary artery stenosis, right ventricular hypertrophy, a ventricular septal defect, and then shifting of the aorta, resulting in problematic, lots of deoxygenated blood going out to the body. So going on to congestive heart failure, this is a fairly prevalent problem in the United States, and it's usually secondary to hypertension or high blood pressure and coronary artery disease. So that heart has to work so hard pumping against the higher pressures in the vascular system, in the arterial system, and then with coronary artery disease, it's not getting fed as well with blood and oxygen as it needs to. So this poor heart tires out, and the left ventricle cannot pump very effectively. And so therefore the fluids back up into the lungs, and they get pulmonary edema or fluid in their lungs, and they will become short of breath. Then the fluid will back up to the right side of the heart and eventually to the periphery of the body, which will cause edema or swelling in especially the lower extremities of the body. Coronary artery disease we've kind of talked about, but this is when that arterial sclerosis or atherosclerotic plaque builds up in the artery, blocking off some of the flow. And then if there's an injury or a tear to there, a clot might form on top of this, completely occluding off the vessel. And the person, if this is happening in their heart, may have angina or angina pectoris. And this is chest pain, pressure in the center of the chest, radiating up to the jaw and down the left arm sometimes, or some people feel it in their shoulder blades. And we're concerned that this area of the heart that is not getting enough blood flow, ischemic, might actually become necrotic, death of that tissue, or infarction, death of that tissue. And that would be myocardial infarction or a heart attack. So we want to prevent that from happening. Endocarditis can be viral or bacterial, and endocarditis, inflammation of the inner lining of the heart, and that's also where the valves are. So you can get this vegetation or these little cauliflower looking vegetations on the valve, and that can prevent the valves from closing completely. Hypertensive heart disease is that heart working so hard pumping against the high blood pressures. Mitral valve prolapse can happen more commonly in women, but there are these little connective tissues that hold the leaflets of the valves to allow them to open or close. Sometimes they can droop or fall, and then that leaflets of the valve may not close completely, and blood can flow or regurgitate backwards. With that, we may watch. They may not be too symptomatic, but we may hear those murmurs or that swishing in there of the backward regurgitating flow. And if it gets severe enough, we may have to do a mitral valve replacement. Pericarditis, is in your book, is inflammation of the outer covering surrounding the heart. Rheumatic heart disease is from rheumatic fever, and it can cause damage to the valves as well. Aneurysm is one of the things I wanted you to be familiar with, and you can see in your book and here on the slide, it's a bulging, widening of the vessel. This is an abdominal aortic aneurysm, but it can happen in any of your vessels. And our goal is to monitor it and do surgery on it before it's at risk of rupturing. And when we do surgery, we'll put a graft in there, both above and beyond the aneurysm, and the flow will go through that graft then. Sometimes we leave the extra tissue as insulation, and sometimes we remove that. So that's an aneurysm. Deep vein thrombosis. With deep vein thrombosis, a clot, abnormal condition of clot occurring in the deep veins, usually in the legs or in the calf area. And you can see how this clot blocks off and really narrows down that lumen. Plus you get a lot of redness and pain, inflammation. And we don't want this clot to break loose and travel through the bloodstream up to the lungs, where it could be a pulmonary embolism, cause shortness of breath, and could even be life-threatening. Peripheral arterial disease can be problems out in other arteries, similar to the arterial sclerosis and atherosclerosis that we've talked about in the heart. There can be blockages and problems with the blood flow there. Raynaud's can happen on its own or secondary to other disorders, and it can be a vascular problem to the peripheral vessels, and so they can get these very whiteness as vasoconstriction or spasm occurs and blood flow is not getting to those fingertips. Varicose veins are bulging, twisting veins, and remember, if they occur in the anal rectal region, they're called hemorrhoids. On the lab tests, I wouldn't stress too much over those, but we can do some different lab tests. Cardiac biomarkers are going to look and see if the heart is having trouble for like a heart attack. Lipid profile is going to look at your cholesterol level in there. So there's some different tests that we can do. Under diagnostic question for you here, inflammation of the vein with also a formation of a clot. See if you can build that word. Thrombophlebitis, inflammation of the vein, thrombo with also a clot in there. Under diagnostic imaging, we can do angiography or angiocardiography, process of recording the vessels or the vessels of the heart. We can go in usually through the groin, up the aorta, through the aortic arch, and then look at the coronary vessels here and see if there's any blockage in there. But we could do angiography of any vessels in the body. This one is specifically angiocardiography. Digital subtraction, because the heart is a beating structure, we can subtract out the blurry images as a simplistic way of looking at that. We can put an EKG on there and subtract out the moving images. CT scan, computed tomography, is using the CT scanner or taking x-rays, sending them to a computer. Usually they look like these images on the right. We can see calcium scoring in the coronary arteries, which gives us a very early indicator of disease, and they should be changing their risk factors in their lifestyle. We usually don't see pictures looking like on the left. It is possible, but we usually are looking at more of these gray images with that. Doppler studies would be ultrasound studies. We can do those of different vessels, and we can see which way is the blood flowing, if it's regurgitating or flowing backwards, and how that goes with it. Echocardiography is one that I wanted you to be aware of, and echocardiography is an ultrasound of the heart. We can do it transcutaneous, or we can also do transesophageal here, where we put the probe down their esophagus and look from the back of the heart. And one of the things we can measure with an echo is the ejection fraction, or how much blood is being pumped out of the ventricle with each contraction. And it'll never be 100%, but 60% is a nice norm. Somebody that has heart failure or is awaiting transplant might be around like 10%. We also can see if they have any regurgitation or backward flow with that as well. This is a MUGA scan, is a nuclear study that we can look at the function and the muscle movement of the heart if we're concerned that after like a heart attack they may not be moving the muscle completely. We can do some cardiac catheterizations we talked about to do the angiogram, usually going up the aorta to the coronary arteries, which is a left heart cath, but we can go up the vena cava in a vein to the right side of the heart and measure the pressures on the right side of the heart in the pulmonary artery. Not done as often. Stress testing, we can put you on a treadmill and we can see how your heart does under exercise with this. And with that, we can see if you have any abnormalities or arrhythmias. If you're unable to exercise on the treadmill or to tolerate that, we can do a chemical stress test where we give you a drug and then stress your heart that way and see how it reacts. So we've talked about ECGs or EKGs, electrical monitoring of the heart, but sometimes we want to see what your heart is doing when you're not necessarily with us. So we may put on a portable ECG or a Holter monitor and send you home with it for 24 hours or longer, and you'll wear this, and sometimes there's a little button on there that you'll push if you have any funny sensations or if you think you're having an arrhythmia, and then the doctor knows to zero in on that's what the symptoms are that you've been talking about, and he can see what your EKG is doing. So that's a Holter monitor with that. This is just showing you some different rhythms, and you have some in your book as well. Do not stress over this. We are not an EKG interpretation course, but that first one on this slide is a sinus rhythm, normal. That second one on the top there is atrial flutter. The atria is moving many more times than the bottom of the heart, and that's fine. Many people live with that and are fine. The one on the bottom left is atrial fibrillation. Again, many people live with that. And then the last one is ventricular tachycardia, which can happen with or without a pulse. And if you don't have a pulse, we'd want somebody doing CPR and bringing the defibrillator. So what is the term for a portable ECG? Correct, it is a Holter monitor. So we're going to talk about some of the treatment procedures. First, in your book you have ablation. If you are having arrhythmias or dysrhythmias, we can try to find the irritated cell and kill it off with a laser. It's called ablating it, so that you don't have those arrhythmias anymore. Coronary artery bypass grafting. If you have blockages in your heart and we need to do surgery for it, we can take an artery that's already in the thoracic wall and attach it past the blockage. Or we can take a vein, usually from your leg, sew it onto the aorta and past where the blockage is in the heart to bring that blood flow. So coronary artery bypass grafting, or CABG. So what does the C stand for in CABG? Coronary, correct. Defibrillation, we've talked about a little bit earlier with the internal defibrillation. You can see the internal defibrillator there in the center in the left upper chest. And then we have the AEDs out there in the community that anyone can use along with CPR to save lives. And then on the right is an example of one of our traditional defibrillators that we can use in the hospital, which the AEDs have the same technology as our traditional defibrillator. They're just packaged in a safer way for the community to use. Here again is an implanted pacemaker, or an AICD, automated implanted cardioverter defibrillator, and you can see it on the x-ray. Sometimes they're also in conjunction with a pacemaker, which would keep your heart beating fast enough if you were having bradycardias. Endarterectomy, if you have vascular disease where you're building up atherosclerotic plaque, then this one is in the carotid. We can go in and remove that inner lining, the endothelial lining. So we're going to remove the inner lining of the artery and the fatty plaque in there, endarterectomy. If there's a clot in there, we might do a thromboendarterectomy. Extracorporeal circulation is a bypass machine that we put you on when we're doing open heart surgery, which will oxygenate and pump your blood for you while we're doing surgery. Cardiac transplantation is a growing need. Every year, more than 2,000 Americans are in need, and the donor shortage does affect that. And your book doesn't talk about, but I want to just expose you to, this is a left ventricular assist device. This was a gentleman I got to meet a few years ago, and he was awaiting a heart transplant. In the meantime, his ejection fraction was less than 8%, so he carries around this pump always with him. It takes some blood off of his heart, sends it through this machine as it flows through there. These are 2 battery packs, and then enters it back into his body again. If you're interested in this, there is a short little video on Blackboard from this company kind of explaining how it works. But this machine in particular is not pulsatile, so it doesn't pump, it just circulates the blood. So interestingly, he has no pulse because it's constant flow, and his blood pressure is a constant number. He does need to stay on this all the time. It always has to be with him. It runs on 2 batteries, and then at nighttime he plugs it in as well. So just an interesting left ventricular assist device while he awaits for a heart transplant. But this allows him to go through and still live his life and work while he's awaiting for heart transplant. So back to your book, it talks about percutaneous coronary intervention, or another name is percutaneous transluminal coronary angioplasty, surgical repair of the vessel by going through the skin and through across the lumen of the vessel. So in your coronary arteries, if you have blockages here, as you can see here, we can pass a catheter down the lumen to where the blockage is, and on that catheter is a balloon and a little stent, and we inflate the balloon, and then we smush everything kind of out of the way here, and then we deflate the balloon and take it out, but we leave that mesh stenting in there, kind of holding open that vessel to make it more patent or open. This is not in your book, but just something, again, I want to expose you to is transmyocardial revascularization. This is done sometimes, and they actually kind of drill with a laser little new pathways in the myocardium, and then sometimes they put stem cells in there, and the hope is to grow new blood pathways and new blood vessels in there to help revascularize the muscle. So just some interesting concepts. So what is the term for a surgical puncture of the sac surrounding the heart? See if you can build that. Pericardiocentesis is the correct answer there. Your book has some abbreviations. I wouldn't stress over those too much, except for the few that I did ask you to be aware of, ECG and echo, and we'll get back to that in just a minute. Here's another clicker question. A term that means fainting is syncope, means to pass out or to faint. And so that brings us back to patent, meant that it was open. Aneurysm was a widening of a vessel. Cyanosis is an abnormal condition of blue due to decreased oxygen to the tissues. Deep vein thrombosis is a clot that forms in the deep veins, usually in the calf or the leg. ECG or EKG, electrocardiogram or electrocardiography, process of recording the electricity of the heart. Echo, for echocardiography or echocardiogram, is an ultrasound of the heart, and we use the term echo because it's bouncing off that moving heart. Hemorrhoid is a varicose vein or a bulging, twisting vein in the anal rectal region. Ischemia is the condition of holding back blood flow from the tissue, and then we worry that it might become necrotic, or we might have an infarction, like a myocardial infarction, a heart attack. Sphygmomanometer is the instrument to measure your pulse pressure, or more commonly known as your blood pressure. Tetralogy of Fallot was a congenital defect of 4 defects of the heart, and it can result in very traumatic, having the deoxygenated blood circulated to the body. So I hope that helps with your cardiovascular chapter. Continue to study your word parts, building and breaking down those words. Thank you much.